afternoon to all of you. We are lucky that with the initiative of our API holders, Dr. Parikh, Dr. Mathur sir, has motivated us to start this certificate course of obesity, which is a very important topic for all of the physicians because the number of diseases are associated with it. And we had 6 lectures earlier, and today we will have 7th and 8th lecture. And before we go for the scientific program, I will request Dr. K.K. Parikh sir, who is the mentor and godfather of all of us physicians of the Rajasthan, and he always keeps us motivating for conducting CMEs and all these things. Dr. Parikh sir, will you like to say?
Thank you, dear, for your kind words. Good afternoon, dear friends, ladies and gentlemen. It's really a great pleasure to welcome all of you on this 4th module of certificate courses on obesity. I would like to extend my sincere thanks to our President API, Dr. Girish Mathur, and Dean ICP, Dr. Jyotirmay Paul, and the coordinator, Dr. Prakash Keswani, for conducting such a great academic program on obesity. And we all know that obesity is one of the biggest risk factors for the non-communicable disease, not only in India, but all over the globe also. So this academic program will benefit to all physicians and clinicians to a great extent in making, awareing all doctors, clinicians to aware their patients about the obesity and related disorders. We have got 2 great speakers, Dr. Nitin Kapoor and Dr. Sanjay Saran. Dr. Nitin Kapoor will be speaking on the association of diabetes and obesity, and Dr. Sanjay Saran will be talking association between obesity and sleep apnea. These are both 2 very important things. And these sleep apnea, we all know that it itself is a big risk factor for so many diseases. So we will having a great academic program today, and I hope that we'll be greatly benefited with this program. I thank you again, our speakers, Dr. Sanjay Saran and Dr. Nitin Kapoor, for being on this platform to sparing your valuable time. Thank you very much, everyone.
Thank you, sir. Thank you, sir, for your kind words. And we hope that you will keep on showering your blessings on us forever.
Thank you.
My good afternoon to Dr. Girish Mathur, sir. A very dynamic, still looks and is young and has made so many good things in short tenure of his presidentship in the API. With his inspiration, this program has been started. And I will like to invite Dr. Girish Mathur sir to please say a few words for all the participants and the physicians of the India.
Thank you, Prakash ji. Honorable Dr. K.K. Parikh sir, Dr. Prakash Keswani, course director, and all friends. I extend a warm welcome on behalf of API to all of you. Today, we are going to have a 4th session of this ICP certificate course on obesity. This certificate course is getting great feedback and appreciation from all the participants. Scientific content of the sessions is exceptionally well, and the participating faculties are leaders in their field. Today also, we have got 2 distinguished faculty, Dr. Nitin Kapoor, who is Professor Endocrinology at CMC Vellore, who will speak on diabetes and obesity, and Dr. Sanjay Saran, Associate Professor, SMS Medical College, Jaipur, who will be speaking on obesity in obstetric sleep apnea, a very common association. My congratulations and compliments to Dr. Prakash Keswani, Project Director, for his very sincere efforts and hard work for preparing these modules and this program. My best wishes for the success of the program. Thank you so much.
Thank you, sir. Thank you very much for your kind words. Now we proceed for the scientific program. Today we have two important topics. One is the diabetes. We know that every second man is suffering from diabetes, and obesity really affects development of the diabetes and the course and the prognosis of the diabetes. Both have good association. Other is obstructive sleep apnea. We know that OSA can cause obesity, and obesity definitely causes OSA. And both are important, interlinked with each other. And we have two brilliant speakers. One is Dr. Nitin Kapoor. He's a young academician, and he's a professor in the endocrinology at CMC Vellore. He will be speaking on obesity and its association with the diabetes. Without wasting time, I invite Dr. Nitin Kapoor to please start your deliberation.
Thank you so much, sir. Thank you, Keswani, sir, for this kind invitation. And it's my honor and privilege to be presenting this in august presence of Dr. K.K. Parekh and Dr. Girish Mathur, sir. In the next couple of minutes, I shall take you through this topic on the association between diabetes and obesity. And though this topic at one glance looks pretty simple, because we all know that diabetes and obesity are well connected to each other, but I feel that there are several small facets that we need to look at when we talk about this particular topic. And it is important to understand these very small individual facets of diabetes and obesity to get to the bigger picture of the bigger problem of diabetes. So I'll be covering these in the following headings. We'll start straight with the problem statement. And I think all of us are well aware that diabetes has reached pandemic proportions globally. This is data from the IDF Atlas, which was published in December 2021. We know that countries like India and China lead the world with the world's largest number of people with diabetes. Yes, it is often due to the population that is there in these countries. But when we talk of the number of people with diabetes in India, it's about 74 million. But the sad part is that about 53%, about half of the people with diabetes in India don't even know that they have diabetes. They are undiagnosed. Well, several reasons to explain this. One, obviously, lack of awareness, the asymptomatic nature of the disease initially, and less screening practices. But also another reason possibly is that unlike the West, our patients don't look so morbidly obese or obese and still have diabetes. And so that thought does not crop in that, oh, this patient should be screened for diabetes, even though we are at very high risk. So yes, that's about diabetes. When you talk of obesity, I think it has reached pandemic proportions across the globe again, across different age groups. This is a study we did in Vellore a couple of years ago. This is in school children between 12 to 16 years. And what we found was that 1 out of 3 school children in Vellore have obesity. And believe me, Vellore is not first tier city. It's at best a second tier, mostly a third tier city. And still, we have such a high prevalence of obesity in school children. When we looked at data from the Vellore birth cohort, which is another very big database, probably the oldest birth cohort which is available in India, and we see that there is a rapid increase in the prevalence of obesity, especially so in women over the last 10 years. Are elderly spared? This is a study we did in rural women, elderly rural women. The mean age was 60 years. Again, a very significant proportion of them have overweight and obesity. Looking at national statistics, when we looked at data from the National Family Health Survey, over 6 lakh patients were studied. Again, 35 to 40% of them have obesity. But today's topic is mainly on the association of diabetes and obesity, something that can be together called as diabesity. So when you look at literature with respect to that prevalence, and in the study which was done in Cordially, in Jaipur, and they looked at that how many people with diabetes would have diabesity, and that's again a big number of 67%. So yes, diabetes is common, obesity is getting common, and it is affecting all age groups. Together, in people with diabetes, about 70% of them have obesity. But when we still look at the global map of obesity prevalence, we see that countries like India are still one of the lightly shaded countries. We probably don't have that much obesity as in the US, though it's definitely increasing. And this was very nicely plotted by this uh, author, Keith et al., in this paper, which was published in 2016, which showed that in India, we have a lot of diabetes, and you see the prevalence is amongst the top layer of countries in the world, and this is the prevalence. So it's not based on the population, this is based on the frequency of people who have diabetes. But when we plot it against obesity, we seem to be having one of the lowest prevalence of obesity, but the highest prevalence of diabetes. So there seems to be this paradox that we need to understand, and this is what is explained in the second part of my talk, which is talking about the kg-A1C paradox. You know, kg is for obesity, A1C is for diabetes. And though when the kg-A1C paradox was first proposed, it was not with respect to what it is seen today. Initially, when kg-A1C paradox was proposed, they said that when we start managing patients with diabetes, what happens is their HbA1c come down, but their obesity starts to increase. Now, conventional school teaching is that as the weight increases, the diabetes prevalence will increase, and this has been shown in different familial studies. Obviously, if you have family history of diabetes, the steep is much larger. But it is not uncommon in clinical practice, and all physicians on board here would agree with me. It's not uncommon to have sometimes a patient who's not so obese, maybe about 30, 35 years old, has about 200 to 300 milligrams per deciliter of glucose values, not ketotic, not really fitting like type 1, not very obese, no acanthosis. So I think there is a significant proportion of population which also has this phenotype. Yes, at times we have people with high BMI also who have a lower diabetes prevalence, a phenotype called as metabolically healthy obesity, which itself probably is a misnomer, and I won't get into that. That's a separate topic for discussion. But when we focus on people who have a normal BMI and high diabetes, and we looked at it in a community-based study a couple of years ago. We studied 5,000 patients in the community in rural Vellore. And what we found was that 1 in 20 in the rural areas have a BMI of 18.5 or less and still have diabetes. And this is what the kg-A1C paradox that we deal with today. Now, putting this in a clinical perspective, when we are sitting in a clinic and a patient walks into our OPD for diabetes management, what would we do? We would have a patient, we could classify them as either normal weight, we could classify them as overweight or obesity, or sometimes in the far end of the spectrum, we would classify them as morbid obesity. And this we would do based on two things. One, based on an obesity indicator that we choose. Second, the cutoff of the obesity indicator that we use. And the most common obesity indicator that is used globally is the body mass index. Now, yes, this was designed or described first time by Rodolphe Quetelet, who's a mathematician almost 200 years ago. But over the last few decades, we know that BMI is probably not the best indicator for obesity, especially in light of diabetes for our Asian population. We know that we tend to have much more body fat despite having low BMI. And this has led to the new phenotype that we describe as normal weight obesity, when people have normal BMI, but high body fat. How is it defined? Yes, people who have a non-obese BMI, BMI of less than 25, but the body fat percentage is high. And this is something that needs to be kept in mind when we practice in India and we're talking about diabetes management. Not everybody is going to be very obese, and this is an association. We look at the prevalence of normal weight obesity in a study that we did in a cohort in Kerala. And what we found was that 1/3 of the study population had normal weight obesity. And this was 2/3 of the people who have so-called normal BMI or non-obese BMI, BMI less than 25, had high body fat. Now, how is it connected to diabetes? When we look at the prevalence of diabetes, hypertension, dyslipidemia in these patients with normal weight obesity, it is definitely much higher than people who do not have high body fat, but it is very similar to people who have obesity. So yes, this is important. This is something that is common in the South Asian phenotype. This is a meta-analysis that showed how the South Asian countries have a very high prevalence of this normal weight obesity. And this another meta-analysis which shows the risk of developing diabetes in people with normal weight obesity, the odds is 1.6, almost 60% higher chance of developing diabetes in people with normal weight obesity. In our study, we followed up these patients after a lifestyle intervention for 2 years. And unfortunately, what we found was that these patients with normal weight obesity seemed to be very resistant to change. And what was the only change was probably a little change in blood pressure and cholesterol, but their diabetes status did not change. And this is endorsed by the recent Endocrine Society of India practice guidelines for management of obesity, as well as the RSSDI guidelines, which have a special section on normal weight obesity that we talk about in terms of diabetes. So this was the second section of my talk. And though I talked about the prevalence of diabetes, obesity, and both of them together, I think from an Indian perspective, we don't always think of BMI, but we have to look at body fat also possibly as a factor. And this explains the KG-A1C paradox. Now, again, talking about diabetes and obesity, what is the reason why these two diseases concur often in clinical practice? And I think one of the major reasons would be the dietary practices. Now, this was the famous START study done by Dr. Shashank Joshi, and we know that about 60 to 70% of our Indian diets, irrespective whether it's North, South, West, or East Indian diets, is essentially made of carbohydrates. Another paper by Dr. B. Mohan, where again we compare either rural or urban diets, or even when we compare it to Western diets, we tend to have much higher carbohydrate and much less protein. When we looked at data from our own clinic, and this is data from the obesity clinic in Vellore, and all patients in this clinic have a BMI of more than 35. And despite that, most of the patients do not meet up to their protein requirement that they should be taking for what is recommended for them. So when we talk of diabetes and obesity association and the consensus we wrote on the dietary aspects of the medical nutrition therapy, I think there was one point that I had to highlight was that we have to have enough protein intake. I'm not talking of high protein diet, but just to improve to normal protein, what is recommended for them. A couple of years ago, again, we did this study in which we had patients with diabetes, and we just gave them, in the cases, a meal which had the normal amount of protein that is recommended, and in controls, the usual diet. The calories in both the cases and controls were same, but just by increasing the protein to the normal recommended value, the line in green that you see, how the spike of glucose can be come down. So when you're talking of dietary practices in terms of the common association between diabetes and obesity, I think a big message is that yes, carbohydrate intake is very high in the Indian setting, and the protein intake is low. Well, there's several ways in improving the protein intake in the diet. In this paper that we were involved with, Cheryl Salis, she's given very nicely how individual diets, north, south, east, west, we can improve the protein in the southern part where the people commonly eat dosa, how we can improve the flour of that batter of dosa by adding those lentils. Similarly for north, south, east, west, and I think this is something important. Another important way of assessing diets, and most recent literature now talks about food groups rather than just looking at individual food items, because if I tell my patient, yes, chana is good, but if that chana is going to be eaten with a bhatura, the whole point goes down. So now more and more literature talks of dietary patterns together rather than just looking at individual food components. And yes, again, the high carbohydrate rich patterns have the worst kind of outcomes in terms of diabetes and obesity. So yes, this is all about the macronutrients so far. And if I may say that what we've learned in classical medical school teaching, that there is protein, carbohydrates, and fat as the three major macronutrients. If I may want to add another macronutrient, and that would be fiber. Now we know that dietary fiber itself has several ways in which it increases the insulin resistance, but is also important in helping to reduce weight. I'll just show you an example of a classical breakfast in north, south, west, and east zones of India. All these breakfasts have exactly the same calories, but you look at how the fiber content is very different. And this is another important area, probably because of the low fiber diet that we consume, that has increased the epidemic of diabetes and obesity together. Well, we've talked about macronutrients in diet, we've talked about fiber, But very recently, emerging literature is coming up also with respect to the micronutrients. A lot of data on this from Dr. Yagnik's group. This is a paper we published very recently, accepted last week, in looking at the micronutrients in children, in over 1 lakh children in the national survey, and how folate and iron are important with respect to making sure that the risk of obesity can be reduced. So we've always focused on macronutrients, but even the micronutrients seem to play an important role. A lot of work by Dr. Yagnik in how giving iron and B12 and folic acid in the pre-pregnancy time to the mother has a big impact both on the mother and the child. So friends, this is just about the diet, but are there other factors, common grounds for why we have this pandemic of diabetes and obesity? Possibly, yes. Well, there's several other factors. In this recent declaration that was signed in Kathmandu by the South Asian Federation of Endocrine Societies, again, what we see is that there's several reasons why we as a South Asian phenotype tend to have multiple reasons for developing diabetes and obesity together. Well, there's several reasons on the flight, but if I had to pick up one reason of all that is mentioned, I think low birth weight is something which is a common or a mother to both the diseases. Again, a lot of work from Pune on this, and including data from Vellore, where we've seen followed up patients with low birth weight 20 years down the line, and we see how metabolically, both in terms of diabetes and obesity, it is very, very rampant. So yes, low birth weight is important. I will fail in my responsibility if I do not mention about the use of steroids. And this is another example. This is a 60-year-old lady who came to me with florid Cushingoid features, and her ATM cortisol was suppressed. And I was quite certain that she's taking some kind of steroids that have probably caused the phenotype of both obesity and diabetes and all classic Cushingoid features. And she would deny that she's not taken any tablet, injection, or any other kind of native medications. It was only during ward rounds that I find this particular packet lying to her bedside. And she says, "Doctor, ये तो बहुत ही अच्छी दवाई है. This is like for my जोड़ों के दर्द के लिए आप अपने patients को भी दे सकते हैं. This will really, kind of improve." And when we analyze this, this is dexamethasone. So this is another thing which is rampantly misused in our country. When we looked at data from our obesity clinic here in Vellore, we found that about 5% of patients are on exogenous steroids, and many of them don't even know that they are taking steroids. This is another sad story of two young boys who presented with diabetes and obesity. Their ages are 18 and 20. And when we looked at, why do they have Cushing's? So somebody has given a powder to their mother to help to increase weight, and she's diligently mixing in milk and giving it. So yes, steroid use or abuse is also another very common aspect that we should not miss when we talk of the common origins of diabetes and obesity. Well, with this, let me move on to the complications and consequences which are common for diabetes and obesity. And I think in this August audience, we know that with diabetes and obesity, probably every organ system is involved. We know all the micro and the macrovascular complications of diabetes. We know that obesity can lead on to probably several organ system dysfunction. But if I was to pick up three, which are specifically common to diabetes and obesity, but at the same time not often discussed and have a high prevalence, the three that I choose to discuss in a little more detail is the liver, muscle, and the bone. Talking about liver, and this is talking about metabolic associated fatty liver disease, the new name for NAFLD. And this is a paper we recently published in Endocrine Clinics of North America. Yes, we know that NAFLD or MAFLD is common in people with diabetes. About 55% of people with diabetes have MAFLD. But the good thing is that these newer anti-diabetic agents which are there in the market are helpful in reducing the prevalence of MAFLD. And what was classically taught to us when we were students is that, okay, once you develop a stage of fibrosis or later on cirrhosis, or if you have steatohepatitis, it's a progressive disease. But that has been disproven now with the help of newer trials, the LEAN trial with liraglutide, trials with semaglutide. It has been shown that MAFLD can be reversed if by the using of these newer anti-diabetic agents like GLP-1 analogs and SGLT2 inhibitors. So yes, this is something which is good to hear, but at the same time, this has to be something which is to be screened regularly, which is often not done. Again, when we looked at data from our obesity clinic here in Vellore, we find that about 75% of these women who walk in to the obesity clinic have underlying MAFLD. So that was one aspect, the liver. I think another aspect which is commonly missed out in terms of complications of obesity and diabetes is the bone health. Again, the RSSDI clinical practice guidelines, which was published in October last year, has given a special section on screening for osteoporosis in people with diabetes. Today, with literature, we know that osteoporosis, the most common cause today is diabetes, which is again something which is not screened. And this is also something that has been endorsed by the Indian Society of Bone and Mineral Research Clinical Practice Guidelines, which was published in June 2021, about screening for diabetes, also endorsed by several Western guidelines. We in Vellore looked at this as an original study, looking as bone health in people with diabetes. Surprised to find that about 1/3 of our patients with diabetes had vertebral fractures. Similarly with obesity, and again, against the conventional teaching, which is said that as weight goes up, your bones become stronger. But once somebody reaches morbid obesity, very severe obesity, we are often telling those patients not to eat more. They are often restricted in terms of their movements outside to get exposure to sunlight. Again, they have so many inflammatory factors, right, from OSA to fatty liver, all of them which have been negatively correlated with osteoporosis. And I think the study did prove that as women have severe obesity, their bone health starts to deteriorate. And this is something that has to be looked at. Again, common between diabetes and obesity. And the last part in terms of complication that I want to discuss, which is something, again, that is not discussed very well, is the muscle aspect, and that is called as sarcopenia. And low muscle mass is, again, something which is common to both diabetes and obesity, especially in sarcopenic obesity. This is how we assess sarcopenic obesity in this paper, which was looked at how sarcopenic obesity leads on to diabetes, hypertension, dyslipidemia. You see the odds ratio there in the study, 8.2, 800 times risk of developing metabolic syndrome by just having sarcopenic obesity. In this recent paper, we looked at the prevalence of sarcopenic obesity. It's not uncommon, 1 in 10. But the reason why we shouldn't miss this is, again, looking at this paper where you see the last part of the graph, the line with the small longitudinal lines. We see how the mortality is highest in people with sarcopenic obesity as against to just obesity, just sarcopenia, or just diabetes. So this is also something that we have to look at. So yes, there are several complications and consequences of diabetes and obesity put together, but I think the ones which are less discussed that I put it here is in terms of liver assessment, is in terms of bone assessment, and also muscle assessment. I thought in the last part of my talk, I'll talk a little bit about management as well, how management of diabetes and obesity is also a common ground. I showed this slide before. This is medical nutrition therapy in people with obesity. And we see that how it's a very long article, I think runs into 20, 25 pages. But if there was one thing that I had to pick up in this article, that was to ensure recommended amount of protein intake. With all the data that is emerging in India from different centers looking at reversal of diabetes, I think the term reversal of diabetes is more off, and it is more in terms of remission. But again, it's talking of remission of metabolic syndrome. So both diabetes and obesity being discussed together in terms of reversal. Of the several anti-diabetic agents that we have in our market today, we have either a weight neutral drug or a weight losing drug as an option, and GLP-1 analogs have opened the Pandora's box with respect to very significant weight reduction. We are all aware of the STEP trials with injectable semaglutide, which causes weight loss to the scale of 15%, a dual GLP-1 and GIP agonist tirzepatide giving weight loss to the scale of 21%. And currently in Vellore, we are doing trials with CagriSema. The phase 2 results are actually at par with bariatric surgery. And this is something that we can look at. And obviously, sometimes if medicines also don't work, then we go on to bariatric procedures. And again, we have specific indications for bariatric surgery, which are specific for the Indian setting. So friends, this is how I thought we could best connect diabetes and obesity right from prevalence to trying to understand how the KG-A1C paradox is relevant to the Indian setting. We looked at different aspects of the dietary factors which are common that causes this disease. We looked at low birth weight and steroid abuse, which is important. And we looked at the complications of both diabetes and obesity. So what I would like to conclude with is, yes, diabetes and obesity together is common. It may sound simple that they coexist, but there are small facets that we need to understand in a bit more detail. Talking about high fat in the presence of normal BMI is something very unique to the Indian population. Diet plays a role, not only in terms of low protein that is there, which has to be increased, but even fiber, and more recent literature also talking about micronutrients. Low birth weight and steroids is important. We should not miss out on screening at liver, muscle, and bone strength for these patients. And yes, therapeutics, the future seems to be quite bright. So it is important to look at all of these individual factors to try and get the bigger picture of what is the association between diabetes and obesity. I'd like to stop here, but would be happy to take any questions. I'd like to acknowledge all my colleagues in the department here for some of the work that we've presented. Thank you so much, sir.
Thank you, Dr. Nitin. Really, it was a mind-blowing lecture, and you explained very well each step, how both these can occur together, what are the factors which bring these two disorders together, what dietary problems are there to bring these together, and what association with the various complications. It was really a nice lecture, informative lecture, and thank you very much for it. And please always try to come with us in these kind of the lectures. We will also invite you in the later lectures also. Thank you, Dr. Nitin. Thank you.
Thank you, sir.
Now we move towards our second talk. He is Dr. Sanjay Saran, very brilliant, very active, and associate professor in the Department of Endocrinology in our SMS Medical College, Jaipur. And he will be giving a talk on the obesity and obstructive sleep apnea. Dr. Sanjay, you start please.
Yeah. First of all, I thanks to Dr. K.K. Parikh sir, Dr. Mathur sir, and Dr. Prakash Keswani sir for inviting me on such an academic forum. So without delay, I'm just starting my talk. Let me share my slides. So can anybody share? Actually, it's difficult, sir. I have sent you my slide to you. So here I'm facing some problems.
I am asking Ajay to.
Sir, please send the please send on my mail, sir. I'm
Yes,
sharing the mail.
what is your mail address? You have to inform.
I'm texting, sir. It's
Yeah, I got it now. Is
Yes,
it visible to everyone?
Yes, very good.
Yeah.
So,
So now for next in 30 minutes, we'll discuss on obesity and sleep apnea. So I'm starting my talk with the some problem is there still. Yeah, still I'm facing some problem. It's not moving. Okay. So the agenda of the talk would be first disease characteristic, then epidemiology, then pathophysiology, then diagnosis, and then treatment approaches, and then a benefit of the weight loss. So come to the definition first. So sleep apnea is defined as the daytime sleepiness along with the more than 5 breathing apnea. So apnea is defined as the complete stoppage of the respiration for at least 10 seconds or more than 10 seconds. We see the hypopnea. Hypopnea here also the stoppage of the respiration is more than 10 seconds, but it is not the complete stoppage. Here the hypoventilation occur where the hypoventilation occur in the tune of at least 50% lesser. So come to the disease characteristic. First is the sleep fragmentation is there, then hypercapnia is there, and changes in the intrathoracic pressure is also there, then hypoxemia, increased sympathetic activity, and daytime somnolence. So most important thing is the daytime sleepiness along with symptoms suggestive of sleep apnea. So now come to the classical symptoms and finding in case of obstructive sleep apnea. So first is the breathing cessation during the sleep, and second one is snoring, loud snoring is there, insomnia is there, then sleep fragmentation is there, then abrupt awakening because of the hypoxia or hypercapnia is there, and awaken with the chest pain sometimes patient can present, and depression, irritability is there, morning headache is there, cognitive dysfunction, and also loss of libido is there. So these are various symptoms. Along with this, there is difficult concentration during the daytime somnolence, nocturia is also there. Blood pressure is increased as a complication of sleep apnea, and we see in many patients of sleep apnea, retrognathia is there, or we can see lower extremity edema also. So now come to the obesity hypoventilation syndrome, as we are confusing with the sleep apnea. So here in obesity hypoventilation syndrome is defined as a combination of the obesity and daytime hypercapnia. Here the all-time hypercapnia is there. It is due to increased visceral fat, particularly in obese people, and it is due to restricted movement of the diaphragm and the chest wall muscles. So now come to the epidemiology of the sleep apnea. So here we see the global prevalence of the obesity is increasing like anything. At this time, around 650 million people live with obesity over the globe. And we do not know regarding the overweight people because of the criteria of the obesity and overweight as different in some part of the globe. And we see around 936 million people have the mild or severe obstructive sleep apneas, because the many of the people who are not obese still, they can have the sleep apnea. So we know the prevalence of this obesity or obstructive sleep apnea is higher in men as versus women. It is around 50% higher in the men as compared to women, and it increases with the age up to 65 years of the age. After that is decline. So around 60 to 90% of the adults with the obstructive sleep apnea have the overweight. So now come to the pathophysiology of the sleep apnea. So we know the airway obstruction, it occurs during the sleep. So mainly this is the narrowing of the airway. We do not know. It is not the cause of obesity that leads to airway obstruction or something else. It is usually it is a narrowing of the airways that is congenital. That may be because of the mandible shortening of the mandible, shortening of maxilla, or some other abnormalities. So narrowing of the airways is the predisposing factor that leads to airway sucked during the inspiration of the respiratory muscles. And again, the respiratory muscle tone is decreased during the sleep. So decreased tone along with the narrowing of airways and along with the suck the airways during the inspiration, that leads to obstruction, complete obstruction of the airway. That leads to the sleep apnea, obstructive sleep apnea. Now come to the pathogenesis of obstructive sleep apnea that results in cyclical occurrence of the apnea. So first is we have seen the anatomical predisposition of the airway closure, first thing. So again, it leads to the many predisposing factors that again causes this anatomical predisposition that leads to adipose tissue disposition as compromised craniofacial structure, decreased lung volume. Then again here upper way respiratory muscles injury can lead to this compromise of the upper airways. Then surface tension is increased, and then airway edema can also lead to airway obstruction. So this all leads to decrease this airway airway passage that leads to compromised airway, and that leads to again the obstruction of the airway during the sleep. So the critical dependence of the respiratory rhythm we know on the PaCO2. So again, the PaCO2 is increased during that time, during the obstruction period. So that leads to again arousal, and that time the increased respiratory drive is there. So we know it is because of the motor stimuli on the chest wall and diaphragm, they goes, and chemoreceptor stimuli and arousal of the patients that leads to again ventilatory overshoot. So during this period, the same thing happened with the respiratory muscle tone is decreased, that leads to upper way obstruction. So airway closure, that leads to chemoreceptor feedback to airways and chest wall arousal, then again ventilatory overshoot. So during this period, hypocapnia occurs. So again, the respiratory drive. So we can say that the decreased respiratory drive is there, so that is the cause of central sleep apnea. So sleep apnea is divided into central and obstructive. So central sleep apnea is due to because of respiratory drive is decreased. Now come to the complex sleep apnea, compromise of the central and obstructive sleep apnea. So it is usually the complex. It's not that the sleep apnea is only the obstructive sleep apnea. It is a complex of obstructive and central sleep apnea. We know the obstructive sleep apnea, here the obstruction is there in the airway passage, but in central sleep apnea, there's no obstruction. Here is the brain drive, it's the drive of the brain that is decreased. Now to come to the mechanical consequences of the sleep apnea. So in polysomnography or in the investigations, we see the central nervous system, here one side is normal, other side is the patient with obstructive sleep apnea. So just after the event, we see the EEG is shoot out here. There are a lot of waves are there in the EEG just after the this event. So the yellow line they are showing the event. So just after the event, it is increased. So if we go through the ECG, so ECG again the cardiovascular circulatory system again show it is ECG increased cardiac rhythm or increased heart rate is there. If you go through the blood pressure, so again after the event, blood pressure is increased. And respiratory system, we are going respiratory rate are also increased after the event. During the event, it is decreased. Same thing happened with the oxygen saturation. So saturation is decreased during the event, but it increased after this event. So now come to the risk factor for the obstructive sleep apnea. So these are various metabolic risk factor and other suspected. So in the metabolic risk factor, we see first is the overweight. So we have seen that in the obese patient, we see up to 90% of the patients of sleep apnea, they are obese, or we can say they are overweight, or up to the 50% of the patients of the sleep apnea, obstructive sleep apnea particularly, they are obese. Other thing is the craniofacial and upper airway abnormality. So this is the first thing is the requirement is the craniofacial and upper airway abnormality. Then we need the, if neck circumference is increased, particularly it is more than 43 centimeters, that is 17 inches in men, or it's 16 inches in women. If it is more than that, then it is a predisposing or risk factor for the obstructive sleep apnea. Other suspected cause can be the genetic factor, menopause, nasal congestion due to allergic rhinitis, or something adenoid or tonsillar enlargement, particularly in children we see. Now come to the predictors of the sleep disorder and breathing in the man. So if we see that the age, so particularly its age, so if the age is increasing, the prevalence of sleep apnea is increasing. So if the patient is the male gender, so male patient is twice as common as in female. Or if we go to the neck girth, so if it is neck girth is increased, obviously the sleep apnea, chances of prevalence of sleep apnea is increased. Now to sleep apnea and the obesity. So if we see more than 80% of the adult with obstructive sleep apnea are overweight, and more than 50% are in obesity. So many of the studies have suggested that 25% of the adults with BMI in between 25 to 28, they have at least a mild sleep apnea. So sleep apnea is more common in the obese patient or overweight patients. So obesity, we know obesity is the most important risk factor for the obstructive sleep apnea. If you see every 2 patients out of 3 patients having some kind of every 2 patients of obstructive sleep apnea are having obesity out of 3 patients. So now come to the increase in the visceral adipose tissue, this again amplifies the obesity sleep apnea. obstructive sleep apnea is more when patient is obese, particularly central obesity is there, and also the visceral fat is more. So the line is showing trends towards the when the visceral fat tissue is more, then AHI is more. AHI is the apnea hypopnea index. So it is the measure of the severity of this obstructive sleep apnea. Again, weight gain increases the AHI and severity of obstructive sleep apnea. If we go through this study by the Pepper et al. Was published at JAMA, they have shown that the weight increase in 5 to 10%, overweight increase in 10 to 20%. So again, it increases the around 30% of the cases of sleep apnea more common. So now come to the upper airway obstruction abnormality that contribute and exacerbate the sleep apnea. Of course, it is a requirement for the sleep apnea. First is the retrognathia. We know the micrognathia and retrognathia both can contribute to the sleep apnea. Then turbinate hypertrophy. Then nasal septum deviation, it can also contribute to the sleep apnea. Then large uvula can also contribute, and large tonsil and adenoids. They are particularly seen in the children's. Now come to the comorbid conditions. So sleep apnea can cause many of the comorbid conditions. It can lead to increased mortality, all-cause mortality, and also increase the cardiovascular mortality. So sleep apnea, it can cause hypertension, other cardiometabolic diseases. It can cardiovascular disease. It can cause systemic inflammation. Hypoxia is there. It can cause type 2 diabetes, mellitus, and asthma. Though we have seen that the insulin resistance is increased with the sleep apnea, but the incidence of type 2 diabetes mellitus is not seen as high as the increment in the insulin resistance. So there are inconsistent studies. They have shown that the sleep apnea causes type 2 diabetes mellitus, or somewhere some study have shown they are not the foolproof data that we can quote. Sleep apnea causes type 2 diabetes mellitus. So now come to the mechanism of OSA contributing to cardiovascular disease. So we know the sleep apnea, again, it can lead to sympathetic overactivity. So sympathetic tone is increased. So sympathetic tone works on the arterial tree first, and then also
So something is wrong. Sanjay, you are not audible.
Not visible also.
Not visible also. Dr. Ghosh should also do. Sanjay,
now is okay, sir.
yes, it's okay. But not share the screen yet.
Let me share the screen.
Today some exam is going on in Jaipur, so there is problem of the net. Yes.
Yeah, sir, here again, it's not playing. So now it's visible, sir.
Visible, audible, but slide has to be changed.
So let me come to the same slide.
I think it is difficult to have video to run during webinar. It's better to skip if you can.
So now, we were discussing with the comorbid condition related to the OSA. So OSA can cause hypertension, cardiometabolic diseases, then cardiovascular diseases, then systemic inflammation, hypoxia, type 2 diabetes mellitus, and of course it can cause asthma also. So now come to the putative mechanism of OSA contributing to the severe cardiovascular
The
disease.
slide is not changing. Slide is not changing.
Is it okay, sir? Now?
No, the first slide is going on. The first page, obesity and sleep apnea.
You re-enter, otherwise it will not work.
Sir, now is it okay?
Sir, stop sharing, then share it again, please.
Yes,
now
now
okay.
it's okay. You have to move on.
Now is it okay, sir?
Yes, but it's the first slide yet. Yes.
Is it visible, sir?
Yes, it's okay now.
So now, as we were discussing regarding the sleep disorder, breathing and related mortality. So we know the severe obstructive sleep apnea significantly increases the risk of all-cause mortality and cardiovascular mortality. So we have seen here the all-cause mortality when the AHI is less than 5, it is mild. When AHI is 5 to 15, in moderate. When AHI is 15 to 20, when AHI is more than Dr. Harish, please mute yourself.
All other participants, please mute yourself. Except the speaker, all others, mute yourself. Yes, Sanjay, you can start.
Yeah, so we see in normal AHI, the mortality is around, if you are thinking it is the 1, so trend is increasing towards the mortality when the AHI is increased. So it is 1.4-fold increase when the AHI is 5 to 15, when the AHI is 15 to 30, it is 1.7-fold increase when AHI is severe, it is more than 30 when 3.8 increase is the all-cause mortality. If cardiovascular mortality concerned, then again, it is more increase as compared to all-cause mortality in case of obstructive sleep apnea. So now we see the linear correlation between the nocturnal hypoxia and the insulin resistance. So here we see in the left side, the insulin sensitivity is decreased when the hypoxia is there, when the oxygen saturation is decreased. On the other side, we see the insulin sensitivity increase when this oxygen saturation is increased inside the body, as described by the Bohr in their study. So now come to the diagnosis and the untreated OSA. What can be done? What are the risk factors, various comorbid conditions that can be caused by untreated obstructive sleep apnea? So the stroke is increased 3.8-fold, and death OSA can cause the death also, that is increased by 3.8-fold. Hypertension, motor vehicle accident, heart failure, occupational accident, type 2 diabetes mellitus, depression and coronary heart disease, there are other complications that can be caused by the obstructive sleep apnea. Now come to the diagnosis. So diagnosis of sleep apnea particularly mainly based on the history, either during the routine health examination, particularly in India also patients are or we can say the patients are particularly aware of routine health checkup, but that is limited to lab test only, not for the consultation with the doctor. So during the routine health examination, patient complaints or patient partner complaints of snoring or daytime sleepiness. So the screening questionnaires are there, which can help us to diagnose whether the patient or suspect the patient is having sleep apnea or not. So there are various screening questions like Berlin questionnaire, Epworth sleeping scale, or stop time questionnaire, or multivariable apnea prediction questionnaires are there. So they can suspect, then later on it is diagnosed by polysomnography. So polysomnography is the gold standard for the diagnosis of the sleep apnea. So these are various stop bank questionnaire where the patients, we can ask the patient, do you snore loudly? So every yes leads to 1 point, or every no that given 0 points. So again, the other question is, do you feel tired or sleepy during the daytime? Has anyone observed apnea or choking during the sleep? Then for T stands for the, do you have the high blood pressure? B stands for the BMI if it is more than 35. Age, if it is more than 50, neck circumference. For the male, it is more than 17 inches. For female, if it is more than 16 inches, and gender male. So the score, if it is 0 to 2, there is low risk of obstructive sleep apnea. If it is in between 3 to 5, further criteria required for the classification. If it is in between 5 to 8, then it is the high risk of moderate to severe sleep apnea. So now come to the severity of the obstructive sleep apnea. So it is graded as the AHI or RDI. So AHI is number of apnea or hypopnea events upon divided by the total sleep time in hours. So we see the per hour of sleep, how many apnea are there. So for the diagnosis of sleep apnea, at least we require the 5 apnea per hour of sleep. And apnea is defined as the cessation of the respiration for more than 10 seconds or 10 seconds. So again, the hypopnea, if hypopnea is there, hypopnea is not the cessation of respiration, it's only the hypoventilation. So the RDI, it's the number of apnea or hypopnea and the RERAS events upon divided by the total sleep time in hours. So if it is severity is graded as the AHI RDI, if it is in between 5 to 15, it is mild. If it is in 15 to 30, it is moderate. If the AHI is more than 30, it's very severe. So come to the OSA, now come to the diagnosis with polysomnography. So with the polysomnography, we see the airflow and oxygen saturation, respiratory efforts, body position, snoring, electrocardiogram, pulse rate, and we see the electroencephalogram. Now come to the treatment approaches. So we know the OSA and obesity, the clinical practical guidelines, they are saying, American College of Physicians, they are strongly recommend to encourage the people with obesity or weight to lose the weight. Then ICSI also, Institute of Clinical System Improvement, they also recommend the patient to encourage the weight loss or go for the bariatric surgery or pharmacotherapy if the patient obesity are having sleep apnea. Now come to the American Academy of Sleep Medicine. They are also recommending the patient to lose the weight in the obesity or obese patients. Now the American Association of the Sleep Medicine treatment guidelines for the obstructive sleep apnea. First, once the diagnosis is established by the clinician or it is supportive of the sleep testing, then the patient is required the treatment part. So treatment part, we ask the patient this various questions, whether it is fit with this CPAP or BiPAP machine. So the BiPAP or CPAP machine trial can be done at the clinic also, or the doctor's clinic also, because there are various APAP and CPAP are also available. So if patients are having some like obstruction is clear cut by the polysomnography, then we consider the initiation of the PAP machine with the lab testing, then consider the initiating the PAP using the APAP at home or in the lab for the titration of the pressure. So once the pressure is titrated, then patient can advise the BiPAP or APAP machine. So now the CPAP, we know the continuous positive air pressure has proven benefits of its own, but has a low tolerability. So it is the gold standard treatment for obstructive sleep apnea. It provides a relief while the patient is in the treatment periods, improves the sleep architecture, improves the nocturnal and diurnal blood pressure, positive effect on the hypertension and cardiovascular disease. Also, it improves the daily functioning also. But poor tolerability is there. The low adherence rate is there. Negative effect on the sleep of the patient's partner is also there. So around 15 to 35 of the patients of the obstructive sleep apnea are not adherent with the CPAP machine. Now come to the benefits of the weight loss. What can cause the weight loss in the patient of obstructive sleep apnea? So we know the greater weight loss that improves the obesity-related complications, as this is beautifully described by my colleague Dr. Nitin Kapoor, that how the weight increases the various complications of the this obesity, or decrease in the weight loss, weight gain, or we can say that weight loss can increase the this morbidity of the patient. So decrease the morbidity of the patient. So we know the decreasing the weight, again, it leads to a decrease in the hypertension or hyperglycemia. If weight decreases in between 0 to 5%, if the in between 5 to 10% weight loss is there, so it significantly improve the glycemia, or it can lead to prevention of type 2 diabetes mellitus, improvement in FLD, and FLD improvement in PCOS and dyslipidemia. If weight loss is in the tune of 10 to 15%, it decreases the cardiovascular disease or urinary stress incontinence or NASH. If the weight loss is the tune of 15 to 20%, again, the improvement in sleep apnea and gastroesophageal reflux disease, or we see the knee osteoarthritis complications are decreased. Or if the weight is in the tunes of more than 20%, then it can lead to remission of diabetes mellitus, and CV mortality is also decreased. Heart failure is preserved, ejection fraction is also decreased. So decreasing the weight loss, we can decrease the obstructive sleep apnea and other complications of the obesity. The symptoms of obstructive sleep apnea is also there. So we see here the weight loss significantly reduces the AHI after 1 year here in this study, or also the mean AHI reduction we see is less than 17 episode per hour is seen here with the decreasing in the weight. So again, here AHI improves with the weight loss in this study where the 72 people have participated, the obesity and the mild OSA for the last study lasts for 12 months or 1 year we see. So decreasing the weight loss and the chances of this sleep apnea or we see AHI is decreased. Now to the lifestyle intervention, if we see here, here we have the various studies, obviously the meta-analysis of the various studies have shown that the lifestyle interventions, again, they decreases the benefit of this obstructive sleep apnea, or they have benefited this obstructive sleep apnea. So dietary intervention, again, cumulatively, they decreases the obstructive sleep apnea, or we see the exercise. So again, here also, they decreases the sleep apnea also. And diet and exercise.
Sanjay, I think there's again some problem.
Yeah.
There are not so many slides.
Yeah, sir.
Also. Try once again.
So we were discussing regarding the lifestyle intervention and the benefits in the obstructive sleep apnea. So we have seen the diet, whether it is diet or exercise, and if diet and exercise we combine, there is cumulative decrease in the with the obstructive sleep apnea is there. We have seen this beautiful meta-analysis. Now again, the AHI improves with the weight loss in the people with type 2 diabetes mellitus. So we see here in this first graph, we see the weight loss. Again, it decreases the this. Is it visible, sir?
Hi. It's not visible but audible. So you can continue with your lecture.
Yeah. So AHI improves with the weight loss in the people with type 2 diabetes mellitus. So if we see the change in the body weight, with the times, so we see the change in the events per hour is decreased with the AHI. So again, we see the various medications which can lead to weight loss. Again, they improve in the obstructive sleep apnea also. So we have this beautiful study. So again, they have shown when we are decreasing the weight, again, that leads to decrease in the AHI also. So the medication, we can use the phentermine or topiramate, or even the liraglutide also have shown the beautiful results with decreasing the weight with the drugs as compared to placebo, and decreasing the AHI also there. So to summarize this all, we see the OSA is more prevalent in people with obesity and males and adults less than 65 years of the age. After 65 years of the age, the OSA incidence of OSA is decreased. Excess weight contributes to OSA by mechanical, inflammatory, and metabolic mechanism. OSA contribute to overweight, obesity, and type 2 diabetes mellitus to the intermittent hypoxia and arousal from the sleep. CPAP is the gold standard treatment for the OSA, but it is poorly tolerated with the low adherence. So weight loss and lifestyle management can improve the obstructive sleep apnea. Therapy can help people with OSA lose the weight, thereby contributing the improvement of the OSA. Thank you. Thank you very much.
Thank you, Dr. Sanjay. Thank you very much for a nice talk. And what I personally feel that obstructive sleep apnea is a neglected problem. Even being in a medical unit, owning a medical unit, in whole of the lifetime, I have prescribed CPAP to only a couple of or only around 10 patients. We don't ask patient about the symptoms of OSA until unless he says that I have sleepiness in the daytime. So it is really a neglected part, what I think, and it has a good relation with the other diseases. And obesity, of course, brings OSA. So you have explained all these things very well. And it was a really nice talk. And we have very good comments also by Dr. Rahul, Dr. Rajesh Gulati, Dr. Anshul, and Manmita and Ankit, and Dr. Yasmin Chaudhary for your good lectures. There's a question for the Dr. Nitin Kapoor. Dr. Nitin, there's a question in the chat box by Dr. Ankit Anand that DEXA scan is used to measure body weight. Is there any simple clinical method by which we can assess the body weight or body fat in clinics on OPD basis?
Yes, I think very relevant question. Overall, when we look at body fat estimation, The gold standard obviously is MRI, which is not possible given its cost and limited availability. CT scan has its own radiation problems. So yes, MRI and CT cannot be done. DEXA scan is accurate, but again, limited availability and cost is a problem. Now, assessment of body fat apart from these measures could be done with the help of bioimpedance. Bioimpedance is fairly okay, provided we provide the correct instructions to the patient before getting onto the machine. And that is something helpful. But even if we don't have bioimpedance, there are other clinical parameters that can be used to estimate body fat. And maybe if I can just very quickly show one paper. This is a study that we had done, I think 3-4 years ago, looking at body fat estimation or visceral fat estimation using a formula. Now, this is very similar to the way we estimate GFR in our clinical practice. When we estimate GFR, we never measure GFR, but it's just estimated using some values. And similarly, this particular thing called METS-VF can estimate visceral adipose tissue very easily. But even taking things even more simpler, I think if you don't have anything, even if primary health center, we can use simple measures like waist height ratio or waist circumference, which will also give us a good idea of body fat estimation. So yes, DEXA is good, but not available. As simple as waist height ratio and waist circumference per se can help us.
So Dr.
Thank you, Dr.
Keswani, can I
Nitin.
have a question?
Yes, Dr. Ghosh.
Yes, actually the question to Dr. Saran, though it's very correlated, obesity and OSA, like your chicken fast or egg fast, what do you think? That obesity starts fast or the OSA starts fast?
Yeah,
What's your
sir,
idea?
yeah, actually obesity and OSA are two different things. So for the OSA, requirement is narrowing of the airways, airway passes, upper airways. It's not the obesity that every obese patient will have the OSA. So they around only 50% of the obese patient they are having OSA.
Dr. Mamta, please unmute yourself. Yes.
So it is not only the prevalence of this OSA, which is more in obese people, or the obesity is a risk factor for obstructive sleep apnea. Obstructive sleep apnea can be a risk factor to the obesity. In various study, we have seen the patients who are obese, who are having the obstructive sleep apnea, so they are obese also. But actually, they are not the things. They are interlinked like that, chicken fast or egg fast like that.
Now, one thing is then, there are plenty of reports, at least I have seen also patient, they are thin, having OSA, becomes obese after having this OSA. Do you have any records or reports or your experience? Thin build, a OSA develop, then it becoming obese also. Is
Yes,
it?
sir.
Yeah.
We have a lot of studies also. The patients who are thin, but they are having obstructive sleep apnea, they become obese, because I have also shown in my slides that the sleep apnea can cause obesity also, along with the cardiovascular disease. So obviously they can be obese, but it's not in the tune of that they can get much weight, or we can say like the BMI, suppose it is previously it is less than 25 and now they are getting like 35 or like that. It's not that kind. It increases the weight, obviously.
So another very important aspect what we found daily basis practice, that large number of patients do not use the machine for a long time. I have got patients at least more than 50%. They use the machine in the initial part of their sleep. Then they woke up sometimes for other reason. Then they do not put the machine. Then it's very difficult to assess the machine's capability for this. Do you have any idea of how to assess the progress of the disease? The improvement of the OSA by doing? Do you require every time a polysomnography or something biochemical test like HSCRP or other metabolic parameter to assess the OSA improving, particularly its metabolic effects?
So for the adherence regarding CPAP or BiPAP, we see this is usually checked on the clinic of the doctors. So at the clinic of the doctors, we prescribe a machine, we prescribe the mask which is fit properly, and it should be very comfortable for the patients. It should not be uncomfortable. If it is comfortable, obviously the patient will like that. So we prescribe this one, but still we are doing these all things, the checking the pressure, what amount of the pressure he require, because nowadays we have the various machines that they can check the pressure, or they can automatically increase the pressure if obstruction is there. So, but still we have to say in the fixed pressure that in the BiPAP machine, you have to use this much of fixed pressure for 2 months or 3 months like that. Then again, we have to see the patient, whether the patient is educated or not. If the patient again complain of daytime sleepiness or not. So doing these all things at the clinic setup, but still we see the adherence is around, it is less than 70% in the most of the patients, because it is uncomfortable, and also it is very uncomfortable for the patient's partner also.
So another very important about the machine, the mode, the automatic mode versus the fixed mode. Because lots of patients have automatic mode, they complain that once they started sleeping properly, the machine disturbs so much that they cannot sleep. What's your idea? Do you have any comment on this?
Yeah,
About-
actually, various societies, they recommend the fixed pressure for the patient. We see the pressure at the clinic during the sleep. Once the pressure is decided, then we advise them the fixed pressure, that you should have such amount of the pressure for the sleep, during sleep. Automatic mode, it can be done, but usually it is for the clinic purpose.
Okay. Thank you. Thank you. Thank you.
Thank you, Dr. Ghosh. Thank you very much to both the speakers, Dr. Nitin Kapoor and Dr. Sanjay Saran. Both have done a wonderful job. And there are a good number of the comments also by Dr. Geeta Arora and so many other doctors. And you, both of the speakers have done very good. Thanks a lot.
Great applause for both the speakers.
Yes.
Thank you.
Both
Sir.
of the
Thank you.
speakers have done good.
Yes. They should be
So,
congratulated.
we leave today, and we will again meet on the 11th June, and we will have two brilliant speakers. One will be the Dr. Sanjay Badada from the PGI Chandigarh. He will be talking about the obesity and bone health, and Dr. Ghosh, he will be speaking on the association of diabetes, obesity with the cardiovascular diseases. Thank you very much, all the speakers, all the participants. And we have received a good number of names, and we have started making certificates also. Today again there is one request from Dr. Yasmin Chaudhary that he has not got registered, but he is listening these lectures. So Dr. Chaudhary, you can send your name, WhatsApp number and email address to this group only, the obesity group on the WhatsApp. We will register your name also. Thank you very much.
I think I should thank you and your team also, Dr. Keswani.
Sir, you are my, we are all one team. We all are one team. We all are speakers, including yourself.
One very good thing of your webinar, that this is probably the most webinar friendly of
Yes,
your webinar. This is very, very important for all of us. Thank you.
Thank you, sir. Thanks for the comments. Bye bye, everybody. Bye bye, Dr. Nitin. Bye bye, Sanjay, Dr.
Bye,
Ghosh,
everyone.
and bye.